This is Pituitary Grand Rounds, an interactive educational program developed and produced by Pituitary World News, featuring doctors and patients in conversations about their cases and the fascinating journeys they embark on as they deal with their conditions.
Greetings, I'm Dr. Louis Blevins from Pituitary World News. Welcome to this episode of Pituitary Grand Rounds. We have a superb episode for you today. I'll be joined by Doctors Julia Chang from Stanford University and Dana Sheely from the University of California, Davis to discuss acromegaly and its management. We will also be joined by fellows at their respective institutions and a patient, Ashley, to delve into acromegaly, its diagnosis, treatment, and some of the quality of life issues that arise in patients treated for this condition.
Hi, everybody. I'm Julia Chang. I'm a neuroendocrinologist from Stanford University. So to start, we'll review the physiology of acromegaly. Acromegaly is caused by overproduction of growth hormone, or GH, from a benign pituitary tumor, also called a pituitary adenoma. Growth hormone stimulates the production of insulin-like growth factor 1, or IGF-1, from the liver. High levels of IGF-1 lead to overgrowth of organs and bones and metabolic dysfunction. There are several symptoms and signs of acromegaly. Some of the most common are growth and enlargement of the hands and feet, enlargement of the brow or nose, larger tongue and thickened lips, teeth spacing and jaw protrusion, thickening of the skin or formation of skin tags, and excess sweating. Acromegaly is also associated with many other conditions, such as snoring and sleep apnea, carpal tunnel syndrome, joint degeneration and arthritis, thyroid nodules and colon polyps, weight gain, diabetes, hypertension, cardiovascular disease, cardiomegaly or enlargement of the heart, and heart failure. In women, irregular menses or hirsutism, which is increased hair growth of the face and body, and acne can occur. And in men, there may be low libido or erectile dysfunction. Headaches and visual field changes can also be symptoms from the pituitary mass itself. For the diagnosis of acromegaly, patients can exhibit characteristic clinical signs and symptoms of acromegaly, coupled with a high IGF-1 level at least 1.3 times the upper limit of normal. However, for borderline or equivocal cases, an oral glucose tolerance test can be performed. This takes advantage of the physiology where glucose should normally suppress growth hormone. So in this procedure, patients would drink 75 grams of a glucose drink, and their growth hormone is measured in 30-minute intervals for 2 hours. And growth hormone above certain cutoffs, depending on the BMI, would be concerning or suggestive of growth hormone excess in acromegaly. There can be a long time to diagnosis after the presenting symptoms and signs. So in studies, almost 60% of patients had an initial misdiagnosis, and almost 1/4 of patients had some type of diagnostic delay. The median delay was about 24 months between the onset of symptoms and receiving the actual acromegaly diagnosis. And reasons for the delay include limited awareness by non-specialists, there not being enough specialists, or challenges with communication between the doctor and the patient. Patients may even undergo surgeries related to symptoms before receiving the actual acromegaly diagnosis and proper management. And this can include surgeries for the head and throat, surgeries for the nose, and thyroidectomy to remove the thyroid, as well as carpal tunnel surgery. And in patients with the longest diagnostic delay, there is increased morbidity and mortality. So I'd like to introduce now our patient, Ashley, who has acromegaly and has been living with acromegaly for several years and has graciously agreed to share her story with us today. So Ashley, thank you for being here with us.
Thank you for having me.
So I would like for you to just start at the beginning and tell us about when you were first diagnosed and initial symptoms that you had that looking back you realized were from the acromegaly.
Yeah, okay. So I was 20 when I was initially diagnosed. I was a junior in college. looking back now, there were a lot of symptoms that people just said, hey, that's just being in college, gaining weight, headaches, tired. I was doing a lot. I was an engineering major with a full course load, and I was in ROTC, so doing military training on top of that. So it was not surprising I was tired and maybe had a headache here and there. And so a lot of those symptoms were just like, oh, you're overworked. It wasn't taken as a medical mystery. That's just being in college. The biggest issue I had was I started getting tunnel vision. And so I started seeing optometrists. And again, it was attributed to eye strain. That's just being in college. You're reading textbooks, you're looking at screens, it's eye strain. And I was given several pairs of reading glasses. And then eventually I went to a third or fourth optometrist, and I was like, listen, I don't have eye strain. Something else is happening. Can we do more tests? Can we look further into this? He came back and was like, hey, your eyes are healthy. I was like, well, that's a lie. Like, I can't see. And he's like, no, your eyes are healthy. We need to look at your optic nerve. And so that really pushed me to go get an initial brain scan to see what was going on. And that's how my pituitary adenoma was found. Saw a neurologist. They said, hey, we need to operate on this immediately. So from having that initial brain scan to getting surgery, it was maybe a 2-week turnaround because they saw a mass and they were like, we need to operate on this now. So getting diagnosed once I actually saw a doctor was fairly quick for me, but it's because I had a scan and there was a mass. It was very, very obvious. It was all of the little symptoms, I'll say, leading up to that where nobody really knew what was going on. And it was just attributed to life and not, hey, you have a disease, like you have a chronic illness that we need to treat, we need to look at. So those were some of the initial symptoms and leading up to everything.
Yeah, and you mentioned many of those other additional symptoms like the weight gain and the fatigue. How many years do you feel like that took from when those symptoms first developed to actually getting your diagnosis?
It's several years. I was struggling with tunnel vision for years before I actually got an optometrist, that final optometrist, to say, you know what, let's look at your optic nerve. So all of that weight gain and, the fatigue and that was piling up even before the tunnel vision started. So I would say 4 or 5 years I was having these symptoms and didn't know to look at my hormones, to look into getting any sort of testing.
Any other symptoms like headaches or changes in the hands or the feet that can be common in acromegaly?
Yeah, so my hands and feet swell a lot. Some days I can wear rings, other days I cannot. Some days my shoes fit, other days I have to wear a different pair of shoes because my closet has 2 different sizes of shoes depending on how my feet are feeling that day. So there are other side effects like that. Headaches all the time. I mean, that's just goes without saying.
Right. And tell me about how this impacted your quality of life, especially so young when you were getting this diagnosis.
Yeah. I mentioned I was doing a lot. I was a very, very active young adult leading into adulthood. And it totally shifted my life. I had to get surgery, and originally I was like, you know what, I'm going to get surgery, I'm going to be cured, and I'm just going to go right back to what I was doing. This is just going to be like a little speed bump. That's not the case.
Yeah.
It's been 9 years, so that's definitely not the case. It's very different living now. There's a lot less physical activities and hobbies that I can participate in. There's a lot of daily pain that I'm dealing with, and trying to work through and figure out how to adjust to this new normal that I have.
Tell me now, when you finally got the diagnosis of acromegaly, how did you feel when you heard that? And did that shift how you were feeling at all, or your perspective on now getting this diagnosis?
Yeah. I think I had to go through the stages of grief. Like originally I was like, no, wait, we're talking about somebody else. This has to be like, denial. Like I can still go back to living my life. Like I can go back and keep doing everything I was doing. And then, you slowly work through it and you're like, okay, well, how do I deal with this? And there's a lot. There was definitely therapy involved to deal with all of the big emotions. And it's, you have a life plan and then suddenly it's ripped out from under you and you're finding a new life at 20.
Yeah, I can imagine just such a big change for you. Yeah, and when you're so young and you have all these plans. Yes. Mm-hmm. So let's summarize Ashley's presentation. At age 20, Ashley was found to have visual field deficits on a routine eye exam. She had brain imaging, which revealed a 3-centimeter pituitary mass. Her labs were notable for a high IGF-1 level of 1,174, and the upper limit of normal was 373. Her growth hormone was also high at 13, upper limit being 7.1, and her prolactin was slightly elevated as well, 33. Her initial symptoms also included significant weight gain of more than 50 pounds over 1 year, an increase of shoe size of more than 2 sizes, and her rings no longer fitting on her hands. She eventually underwent transsphenoidal surgery in New York in February 2016 to remove the tumor, and the pathology of the tumor was consistent with a growth hormone and prolactin-secreting pituitary adenoma. So Ashley, I'd like to introduce Dr. Arita Thatte. She's a first-year endocrinology fellow at Stanford University, and we're very happy to continue to ask you some questions today.
Awesome. It's nice to meet you.
Nice to meet you too, Ashley. Thanks so much. What do you wish that doctors would have known or recognized when you first presented?
A lot of my symptoms, they were not things that I thought I had to go to the doctor for. Like I definitely was like, I was gaining weight. So people were like, okay, we just have to watch what we're eating, work out more. It was, and headaches, tired. I was in college. It seemed like it was normal at the time. There was a lot where I didn't know to go to the doctor. I do wish that one of the original optometrists I saw would have done a more thorough eye exam when I was like, hey, it's not my full eye. It's just my peripheral vision that I can't see. So I wish one of them would have maybe listened to me a little bit better and been like, let's look into that and let's not just be like, it's eye strain, here's some reading glasses. So I think that's the big thing for me.
Thanks for sharing that. So it sounds like the diagnosis process was challenging for you in terms of getting to a diagnosis. Was there a particular part of that process that was the most challenging?
I think it was just knowing to go to a doctor. I didn't know, the symptoms I was presenting could have been a myriad of issues. I didn't know to go to a doctor. I didn't know to ask to have my hormones checked. I think there's a lot that you don't know what you don't know, right? So I think that was the biggest issue for me, was I was dealing with all these things and I was looking at them as individual issues and not trying to put everything together.
Yeah, thanks for sharing that. So it sounds like the diagnosis really happened from the vision changes and the optometry side. Were you also seeing your doctor, or was that really only after you got the MRI and that established the diagnosis?
I was getting yearly physicals, but nobody put together, I listed the symptoms, they were there, they're noted, but nobody put together, hey, we should maybe look into why this is happening. So really the optometrist's point of view was where I was most concerned.
That makes a lot of sense. And then you eventually got to surgery. Did you obtain a cure from surgery?
No, unfortunately not. That would have been the goal, but I did not, and here we are.
Yeah. And next, we're going to talk about an approach recommended to patients with residual or recurrent disease.
Hi, I'm Dana Sheely. I'm an endocrinologist at the University of California in Davis, where I practice seeing patients with pituitary disease. Once a patient has been diagnosed with acromegaly, our attention turns to the treatment. Let me show you the flowchart from the 2014 Clinical Practice Guidelines from the Endocrine Society on the management of acromegaly. Once the diagnosis of acromegaly has been confirmed, most patients should be referred for transsphenoidal surgery with a dedicated pituitary surgeon. After surgery, they'll be assessed to see if they have gone into biochemical remission. And if that's confirmed, patients should be screened with an annual IGF-1 level and random growth hormone. You can also consider repeating the oral glucose tolerance test if that random growth hormone level is detectable. Patients should also be followed with structural imaging, typically with an MRI. However, if after surgery there's persistent disease, there was a very large tumor at the time of diagnosis and the patient was only able to undergo surgical debulking, or if the majority of the tumor was unresectable and the patient was a very poor surgical candidate, we need to consider medical therapy. The indications for medical therapy really should be based off of postoperative testing. So at 6 weeks after surgery, patients should be screened with an IGF-1 level and a random growth hormone level. Keep in mind that it may take 3 to 6 months for the IGF-1 level to normalize. So if that first initial test, the IGF-1 level has decreased dramatically but not normalized, patients may benefit from repeat testing 3 to 6 months down the road. If that random growth hormone level is detectable, it may be appropriate to repeat the oral glucose tolerance test at this time period as well. 12 weeks after surgery, patients should go repeat structural imaging, typically with MRI. And keep in mind, biochemical control is the strongest predictor of patient outcomes. It reflects improvements in obstructive sleep apnea, cardiovascular disease, and glucose metabolism. It may not be reflective of quality of life changes, and structural changes to the heart and joints often do not improve despite biochemical control. If a patient undergoes this testing and it shows that they still have biochemical disease, we need to consider medical therapy. We have a few different options for medical therapy, including somatostatin receptor ligands, and these include the monthly injections, octreotide LAR or lanreotide, the second generation somatostatin analog pasireotide, and oral octreotide capsules. We also can use pegvisomant, which is a growth hormone receptor antagonist, and patients can also be started on a dopamine agonist, typically cabergoline. And in many patients, they may require combination therapy, whether this is a somatostatin receptor ligand plus pegvisomant, a somatostatin receptor ligand plus a dopamine agonist, or pegvisomant plus a dopamine agonist. And the monitoring once a patient has been started on medical therapy. So for lanreotide and octreotide LAR, patients should have an IGF-1 level and a growth hormone level checked after 12 weeks of therapy. This level should be checked just prior to the next dose. This medication can be increased every 3 to 6 months if biochemical control has not been achieved. And in some cases, it may be appropriate to have a longer dosing interval for the lanreotide, up to 6 weeks between dosing. The side effects of these medications, gastrointestinal, patients may experience irritation at the injection site. Up to 25% of patients can develop gallbladder sludge. People may also see hair loss with these medications. With the second generation somatostatin analog pasireotide, this medication has similar dosing and side effects as the lanreotide and octreotide LAR. An important consideration with this medication is that up to 50% of patients may develop hyperglycemia. We see this is generally associated with glycemic control at baseline prior to starting medication, an important thing to monitor for patients on this medication. For the oral octreotide capsules, these were approved by the FDA in 2020 for patients who have achieved biochemical control on the long-acting lanreotide or octreotide. These carry similar side effects to the octreotide injectable medications, obviously without the injection site issues. They are initiated at the time that the next somatostatin receptor ligand injection is due, and they can be titrated quicker every 2 to 4 weeks based on IGF-1 levels and patient clinical symptoms. Pegvisomant. This is a growth hormone receptor antagonist, so we can't monitor growth hormone levels when a patient is using this medicine. We can only monitor IGF-1 levels. Pegvisomant is associated with a benefit on glycemic control, but we need to monitor closely for an increase in liver function testing. And then because this medication has no direct action on the tumor itself, it's important to consider serial imaging for tumor growth, which may occur in up to 6.8% of patients. One other treatment modality that we have in our arsenal is radiotherapy, and also to consider repeat surgery. So for radiation therapy, this may be considered in a patient who has residual mass tumor and a biochemically uncontrolled disease after surgery, despite medical therapy, or for a patient who is unable to tolerate or is unable to obtain medical therapy. You may consider radiation therapy for a patient who has a baseline aggressive tumor, perhaps with a high Ki-67. And it's important to remember that it takes 2 to 3 years to achieve disease control after radiotherapy. The 10-year remission rate is about 50%, although we know that radiation therapy prevents tumor growth in about 80 to 90% of patients. 30% of patients will develop hypopituitarism in about 2 to 3 years, so we'll need lifelong screening for hormonal deficits after they've received radiation therapy. And finally, when to consider a second surgery. So if there's recurrent structural disease, or if a patient has large disease tumor, we consider going back in for surgical debulking to improve the response to medical therapy. Next, I'll have the opportunity to sit down with our patient, Ashley, who you met earlier with Dr. Chang. Ashley, thanks for letting me ask you a couple questions.
Of course.
After your surgery, how did you feel when you found out you had residual disease that still required treatment?
It was a shock. Obviously, I wanted to have surgery and be cured, like magical cure, one-time thing, little speed bump, and not have to deal with this the rest of my life. So it was definitely a shock and an adjustment. But we're now 9 years in, and I am adjusted.
You started on medication. Well, what medication did you start first?
Originally, I tried the cabergoline. It seemed like the best option for my lifestyle. It's just a pill instead of an injection, so it seemed like it would be an easier fit. Did not react great to it. Some nasty side effects, and decided that it wasn't as effective as we needed it to be anyways to control the residual disease. So shifted to try other options after that.
What medication did you try next?
Next, I jumped into somatoline depot, which is a monthly injection. That definitely helped quite a bit, but ultimately did not fully get the IGF levels under control.
And then you eventually stopped that medication, correct?
I did. I lost my health insurance, and that is a rather expensive treatment to be on out of pocket. So I ended up stopping the medication, and I moved and got a new care team, and a lot of life happened.
Yeah.
And eventually my levels were high enough again, and my care team was like, hey, we need to restart this now. So I did end up restarting it.
Yeah. When you were off of medication during that time period, did you have symptoms of acromegaly? How did you feel during that time?
There were definitely symptoms. There was a lot of denial during that period also for me, being like, no, I can deal with this on my own. I don't need to do this. Like, I'll be okay. That shouldn't have happened. But I definitely had symptoms. There was a lot of just general joint pain, the tiredness, headaches, hands and feet swelling, all those very, very typical symptoms were still present.
Mm-hmm. And then when you got established with your new care team and restarted the lanreotide, how have things done since then? Has your IGF-1, I understand it went up to 400.
It went up quite a bit. It's come down quite a bit. Not quite fully under control yet, but definitely way closer to normal. And the treatment definitely helps with symptoms. They're not completely gone, but it definitely lessens the severity of them.
Ashley, I'd like to introduce you to Dr. Vadesh Babu. Dr. Babu is an endocrinology fellow at UC Davis in his final year of training.
Awesome. Nice to meet you.
Nice to meet you as well, Ashley. Is it okay if I ask you a couple of questions?
Of course.
You said that when you were on the lanreotide, it helped a lot of your symptoms. Could you elaborate on that?
Sure. So some of the major symptoms are joint pain and the swelling of the hands and feet. On the lanreotide, I wasn't seeing those as often. I wasn't constantly like every morning waking up and being like, again. There were days where I could wake up and be like, oh, these are hands. These are not like swollen sausages attached to me. I could, wear some of my jewelry more. I could, wake up and I'm not like, I got to take Advil or Tylenol or something to be like, oh, moving shouldn't hurt this much. So on the lanreotide, there were a lot more days, or are a lot more days, where I'm, not having to constantly try to manage symptoms.
Okay. And when you were taking the medication, did you experience any adverse effects?
Hard to say. So the side effects of the medication are also very similar to just symptoms of acromegaly. So it's hard to say, hey, is this happening because of the medication, or is this happening because I have acromegaly? I will say I did lose my gallbladder, so that was removed. And I do believe that was in part due to the medication. Part of that is just there's a history of it in my family, but I do think it was sped up by being on the medication, having gallbladder failure, and so I had that removed. I would say that was the most adverse effect I've had.
Thank you for sharing that. In terms of the challenges that you faced with just getting your medications for this condition, how did it go?
Yeah, it's not easy. Not a fun process, even if you've been on the medication before. There are a lot of phone calls with your insurance company. There's a lot of phone calls with your pharmacy, and having to call your doctor and be like, hey, can you guys do anything? Can you call somebody? Because they're telling me I don't deserve this. And for the most part, everybody I've tried to deal with, my care team has been really, really helpful, or as helpful as they can be, trying to be like, well, we can try. I know it's just hard. You're calling insurance, you're waiting on hold, and then finally you're getting through to somebody and they're saying, well, you actually need to talk to this entity. And then you're like, okay, I'll call that. The pharmacy, and now you're calling the pharmacy and they're saying, no, insurance has to approve this, and you're ping-ponging back and forth, and it's hours, if not days, of work to just get your medication approved and on track.
What did your care team do particularly well in terms of helping you through these challenges?
There definitely was when I would call and be like, hey, I'm really struggling with this. They're saying, insurance is saying one thing, the pharmacy is saying another. Do you know who I'm supposed to be talking to? If there's something you can do. And a lot of that is actually just the secretaries of the offices being knowledgeable, not even having to talk to my doctor about it, which obviously frees you guys up a lot to actually care for your patients. And that, the team just being like, hey, okay, well, we'll see what's the holdup on the insurance end, but you have to deal with the pharmacy or whatever the situation may be. So there's a lot of great information from the care team on how to navigate.
Looking back on this process, is there anything that you think the care team could have done better?
No, I mean, it's just dealing with the red tape of going through the process, the approvals. Everybody wants to have a say on this, that, and the other thing. So it was just the process as it stands now. And the care team doesn't get to decide that. So.
What about that time when there was the gap in your care? Would there have been anything your care team could have done either at the beginning or end of that time to make that time more smooth for you?
If there were other programs, like because I had lost my insurance and I was transitioning. I didn't know what type of health insurance I was going to end up on. I don't know if this exists, but if there was like a program through the pharmaceutical company or something to help so that I could still be on the medication at that time, that would have been information I was interested in. And my care team at the time was just like, oh, okay, I guess you're stopping it. Like, that's your decision. There was no, well, let's look into this. Let's see, maybe there's this. There was no, they were like, oh, okay, you're stopping care. That's your decision.
Were there any differences from the first time you got approval for that medication versus the second time?
So it was 2 different insurance companies. And the first time, I would say it was more difficult. I was having it administered at home. So my parents were trained on how to administer it. So there was the added layer of I had to get approval for home delivery. Whereas this time around, that is no longer an option. The medication has developed. So now I go to an infusion center and have a nurse administer it. So that layer of having to schedule a delivery and have those like at-home approvals were taken out of the equation. And so it was a bit smoother this time around. And the infusion center did help a lot with having the medication approved. Because I was calling. I was like, hey, I need to schedule my treatment. And they're like, you don't have medication here. And I was like, yeah, you guys are supposed to be ordering that. And they're like, okay, I guess we're ordering this. So there was definitely a lot more of also the second time around me just being a better self-advocate. I was 21 the first time I was doing it and not really sure what I was doing. And this time around I was 7 years later, 28. And I was like, no, this is what's happening. I need this. I have really settled into being able to self-advocate for myself.
We've reviewed the symptoms and signs of acromegaly. Unfortunately, this condition is associated with some long-term complications, and many of these, while they improve in response to successful treatment, do not entirely resolve. Cardiomyopathy, even though it's very unusual, is something that can significantly limit the life and functional capacity of patients who have this condition. It seems to be worsened in patients with diabetes mellitus and hypertension. Sleep apnea is seen in a considerable portion of patients with acromegaly. It improves in about 90% of patients who are treated either successfully with surgery or with medical therapy. Musculoskeletal disorders are common. Arthralgias, arthritis, some things that plague most of my patients with acromegaly. Many of these patients will go on to require joint replacement surgery later in life, even years after having their disease tended to. Hypertension, diabetes mellitus, and glucose intolerance are metabolic disorders that often require medical treatment. I've seen some patients undergo therapy and these conditions resolve, while others do require ongoing additional therapy for these complications. Disfigurement is something that we really can't do much about with regards to acromegaly. Once the acral changes and the facial changes take place, they persist, and this can affect quality of life. Unfortunately, many patients lose some of the soft tissue swelling in their face and look even more disfigured after they have had successful therapy. Psychological conditions, namely depression and anxiety, are very common and often influence the quality of life in patients throughout and after treatment. Hypopituitarism requires treatment, and often our therapies are not as good as the pituitary gland would normally be during normal physiology, so that can also lead to changes in what we refer to as quality of life. So let's talk about quality of life. That has been defined as an individual's perception of their position in life in the context of culture and value system in their life, in relation to their goals, expectations, standards, and concerns. Now, most of you would recognize that we're all going to have a different perception of quality of life. We all have different cultures, different goals, expectations, different jobs, different family support systems. So this is a very nebulous thing, and it's different from one patient to the next. Something that affects a patient negatively in one setting may not be an issue for the next patient, for example. But we do know that psychological factors are superior to biochemical control regarding contribution of quality of life during treatment. For example, the depression, anxiety, and the sense of being ill, the negative body image, the fact that people have to take medications which may have side effects, all of those things do lead to different perceptions in quality of life, and everyone responds very differently depending on their coping skills, their past experiences, etc. For all these reasons, it seems clear that psychological features should be addressed separately from markers of disease control to improve the lives of affected patients. For example, you have to treat the depression and the anxiety, and you have to talk to patients about their particular situations with regards to work, family, etc., to be more holistic and take care of the whole patient rather than just the biochemical effects of the disease process. So there are several patient-reported outcome measures, including the ACRO Quality of Life Questionnaire and others that are not disease-specific. The problem with each of these is that they are often employed in research to give an idea of a metric of quality of life, but I think they're best used to assess improvement or changes in with treatment in patients where each patient's serving as their own control, because of the fact that quality of life is a very individual type of an assessment for each patient. The Wilson and Clary model has been proposed as a model that can be used by clinicians to evaluate quality of life measures in conjunction with IGF-1 levels and growth hormone levels. This takes into consideration the quality of life measures as well as growth hormone and IGF-1 levels, but also includes an evaluation of other chronic disorders, treatments, complications and side effects of treatments, age, gender, etc. The improvements are first addressed by normalizing IGF-1 and growth hormone levels, as I had said earlier. That's sort of the premise of therapy and the thing that we know, based on research, will prolong survival and also improve morbidity and mortality of this condition. In evaluating biochemical control and quality of life measures, what has been seen is that 64% of studies showed improved patient-reported outcomes measures with the decreases in IGF-1 levels. So again, that's the first thing we want to do, is to get the IGF-1 level under control. Interestingly, 38% of studies that measured quality of life showed discrepant results between IGF-1 and growth hormone. So that even though IGF-1 improved, quality of life did not, and vice versa. In half of the studies with discrepant results, quality of life measures were unchanged even though biochemical studies were improved. So patients had no sense of improvement in their overall well-being. And this probably relates to the fact that they have a chronic illness, and there's this profile of psychological factors that happen when you're sick and require medical care and have to go see doctors and take medications. So it's important to recognize that this data tells us that we have to optimize management, treat the lingering conditions, the side effects of therapy, and refer for counseling and management of psychological factors such as depression and anxiety that may be affecting the quality of life of treated patients.
Hi, Ashley. Thanks so much for meeting with us, fellows in training, and helping us to learn more about this important topic. Is it okay if we ask you some questions?
Yeah.
So what are the most bothersome complications of acromegaly that you've experienced?
It's the constant symptoms of it. If you're not on any sort of treatment, you are dealing with everyday symptoms. There's headaches, it's fatigue, it's joint pain, it's, little things that people don't consider if they don't have a chronic illness.
And how have these affected your quality of life?
It's definitely been a shift in lifestyle. I went from having a very, very active lifestyle, constantly moving, playing sports, and I had to really dial back that lifestyle. Find some new hobbies that are a little lower impact, puzzling, reading, you know, things that don't put as much physical strain on your body.
How has your care team helped in terms of addressing these deficiencies and the quality of life that you've experienced?
Yeah, I mean, my care team has been great about making sure I'm getting treatment and trying to get my levels under control. That way, the symptoms are controlled. So, getting treatment, making sure my levels are dropping, have helped to lessen the severity of the symptoms. So that's really, really useful.
Did you get any education in terms of expectations as to the complications of this condition?
Yes, I don't think I got enough though. Initially, it was kind of a whirlwind going through everything for me. Finding out, hey, you have a brain tumor, to having that removed was like a 2-week period. And then, I was recovering from my initial surgery when I was introduced to my endocrinologist, and still in the hospital when they're throwing all of this information at you, and maybe not all of that is retained in that state of mind. And so there were some key things highlighted, but there was, I'm still every day learning about this condition. And, I think there should be a lot more information that's readily offered to patients, especially when they're first diagnosed.
Mm-hmm.
Yeah, to that end, kind of what advice do you have to us physicians in training in terms of kind of our approach to caring with for patients with acromegaly, what we can do better to assist?
Yeah, write it down and then give it to them, especially if it's, if you're meeting them when they are just coming out of a surgery or some sort of treatment, in the initial state of mind, when, at least when I was getting diagnosed, there was panic, and your brain doesn't really retain information in that state. So I would say offer like written pamphlets and maybe more information about support services outside of just a physician and a care team, like other support services that are offered, like support groups and stuff like that.
Thanks for mentioning that. Kind of to that question, what do you do to cope with acromegaly in your treatment? And are there other avenues outside of the kind of medical establishment that you found to be helpful in that journey?
Yeah, so I have had the opportunity to connect with other patients, and there are some really good groups to talk to other patients. And I think being able to talk to people that can relate to what you're going through, because you guys understand it from the medical scope in a very like cut and dry, this is what they're dealing with, but to actually be living in it, it's nice to be able to talk to people and be like, oh yeah, I was dealing with this today, or, hey, this started happening. Has anybody else noticed this? Is this an acromegaly thing, or do I need to go see my doctor for this? And it's easier to maybe message somebody else who's going through that, instead of being like, well, this new thing happened, let's go to the doctor, or, all right, well, that's an acromegaly thing, we can just address that at our next checkup.
And I guess last question from my end, what's next for you with this condition?
Hopefully we get my levels under control. We are really, really close, so I'm hoping that we are under control, and then I can just get back to a new normal and hopefully get some of those symptoms really, really out of the way.
So, to summarize the key points that we learned from today, acromegaly is a rare disease, and it's caused by an overproduction of growth hormone from a pituitary tumor. This leads to high IGF-1 levels in the blood. Symptoms can be gradual and can take years to receive the right diagnosis.
Treatment, the mainstay, is surgical, but in some cases may require medical therapy or even radiation following surgery. And acromegaly has many complications, including joint disease, sleep apnea, cardiovascular outcomes that may have significant impact on patient quality of life. It was so wonderful today to hear from our patient who's living with acromegaly and hear some of their experiences with living with the disease and recognize how that may differ from our perception as physicians with the patient experience.
And it was great for our fellows to also hear directly from the patient and understand where there can be gaps in training and hear directly how this disease impacts their day-to-day life.
This is Jorge Fascinetti, co-founder and chairman. Pituitary World News is dedicated to produce content that informs and educates. We are a nonprofit organization and as such rely on contributions to fund all these initiatives. We have exciting plans for 2025. If you'd like to learn more about our plans and help, please visit pituitaryworldnews.org and click on the donate button. You can also help by sharing all the information available on the Pituitary World News website at pituitaryworldnews.org.